start recording now.
Surely, we will start in about 2 minutes.
Yeah, Dr. Abraham, I'd like you to introduce yourself and tell what you're going to talk about tonight. It's all yours.
Will do. Thank you very much indeed. See you.
Okay, just let me know.
At Farah Healthcare Campus in Amman, Jordan, we say good morning to everybody, and we will start this session by presenting the case of aneurysmal bone cyst. As you know, the theme is the clinical, radiological, operative, pathological correlation. And our case for today is the 7-year-old male patient. That's back in September 2017, about a year ago. And the story goes that this patient, just 3 weeks before he presented to us prior to admission, he had right eye proptosis with photophobia. That's the description of his parents. Father and mother says that we noticed this proptosis just 3 weeks before admission. In his past history, there is trauma here in the left frontal area. Head trauma and cut wound scar in the left frontal area. Now, we don't know whether this is related to his pathology or not. We will see. But remember this. His vital signs were within normal. His general examination showed this. You can see the right eye is proptosed. It is pushed outward and downward. So right eye proptosis. This is when you look from the right side, you can see the right eye. See the difference? This is pushed downward and outward. And as we said always that the proptosis is best seen if you look at the head from above. Even this is not good. We cannot really differentiate if it is one. It should be tangential. So this is the only good way of looking at the eyebrow to be at the tangent and looking at the proptosis. He was 15/15 in Glasgow Coma scale. His eye movements were not restricted in all directions. So he had proptosis, but his eye movements were not restricted. No cerebellar signs.
Can we go back to the...
Of course.
If we look at the right eye...
Dr. Ayman Danat, as an ophthalmologist.
The eye is pushed down, but this is not called just pushing down. The whole eye, if you look at the whole eye is moved.
Yes.
We call it dystopia.
Dystopia, exactly. And I left this terminology for Ibrahim Sadat because he's going to comment and he wrote it as dystopia. So no cerebellar signs, gait was normal, no facial weakness. He can close his eyes and smile, so no facial weakness. There was no weakness in his upper or lower limbs bilaterally. And as you can see, this is a healthy young man. Chest X-ray and ECG. Chest X-ray was normal. ECG showed sinus arrhythmia. We'll come back to that later on. The question usually is raised, should we be doing an ECG for a child of 7 years? The answer, of course, is yes. CBC, bleeding time profile is normal. His creatinine was 0.7, and the normal, as you know, is 0.6 to 1.1. So why did I put it in red? Because this, for the patient age, is not normal. Liver functions were within normal. Imaging. We know we are talking about aneurysmal bone cyst. So we're not going to hide the diagnosis. So we better know the aneurysmal bone cyst before we go into the imaging. First described by Lichtenstein and Jaffe in 42, and they classified it into a primary or secondary. Primary, يعني ما فيش أي pathology before. Secondary, there is a pathology, and then the aneurysmal bone cyst developed. The majority are primary. And in the majority of these cases, there is history of trauma. And you have seen that this little boy had a scar of a trauma on the left side. He has the proptosis on the right side, but there is history of trauma to his skull, which goes with the pathophysiology of these aneurysmal bone cysts. Secondary, aneurysmal bone cyst developing on top of the pre-existing pathology. Giant cell tumor, osteoclastoma, blastoma, chondroblastoma, Langerhans, osteogenic sarcoma, etc. Lots of pathologies, they develop on top of them aneurysmal bone cysts due to trauma. So whether it is a primary trauma or a trauma on top of a pre-existing lesion, there is usually a history of supraosteal or intraosseous hematoma. So minor trauma or major trauma cause this little hematoma supraosteal or inside the bone, and then there develops inside the bone a high flow arteriovenous shunting like this. Once that happens, the arteriovenous shunting, the bone will get erosion, so there will be thin cortex, there will be bleeding, and there will be cavities, and these cavities are full of blood. Then the bone collapses and the soft tissue invasion begins. So it's not an easy pathology. So what would you expect in the MRI of the aneurysmal bone cyst? You will find a lytic bone expansion. There is eggshell cortical bone, heterogeneous appearance in T1 and T2. You will find cysts with the fluid levels, and you will find septations, and these septations take contrast enhancement. So to summarize the pathology of aneurysmal bone cyst, it is a blood-filling sponge, bubbly appearance. This one. مريض تحت عليه؟ هلا. So this is the MRI of this patient. You can see this lesion. It is involving the medial wall of the orbit. It's involving the whole of the ethmoid. It's going into the sphenoid. Give contrast. There is contrast enhancement of the septations, multicystic cavities, as we described in the pathology. It's going intracranially. This is frontal sinus being involved. So there is intracranial lesion, but look at this fluid level, because these are cavities filled with the blood, which is caused by the pathology that we described. This is T2, multiple cavities, septations, and we are reaching to the sphenoid sinus. Of course, here the ethmoid is gone completely, so you'd expect that the lamina paplicea here is gone, so the medial wall is gone of the orbit. T2, different stages. This is intracranially. And this is the coronal view. You can see the intracranial extension. Now, if you know the pathology of these lesions, usually they don't involve the dura, they don't invade the dura. So you may say this is intracranial extension. I would say no. This is the tumor pushing the dura above. That's important because this is important in planning of the treatment. But multiple septations, multiple cavities, reaching to the maxillary sinus. So maxillary sinus is involved, medial wall of the orbit, ethmoid completely. As we said, intracranial extension without a dural impeachment. The roof of the orbit here is gone. So medial wall, roof of the orbit, roof of the ethmoid, and the whole of the sinuses. Multiple cystic fluid lesion. Here we are in the sphenoid in the area of the anteroclinoid process. And this is the sagittal section again. The septum, the maxillary sinus, the ethmoid, and the intracranial extension, and the sphenoid. T1, T2. Multiple levels. Remember, this patient is lying on his back, so the fluid level is this. Fluid level, multiple. This is pathognomonic. This can only be aneurysmal bone cyst. There is no other diagnosis. CT show you this bone being eroded in the roof of the orbit. Again, how much of the bone erosion is here. In the ethmoid and the orbit, sphenoid, amount of bone destruction here. Again, I always point to this. The radiography technician is not controlled and he writes names and things here. Pathology is here, so why should you write something in here? Destruction, maxillary sinus. The roof of the orbit is gone. Again here, the anterior clinoid, this is anterior clinoid, this is a wing of sphenoid, this is the orbital fissure, so we are involving here the orbital fissure, the anterior clinoid, destroying them completely. The sagittal CT showing the bone destruction. So, now we understand the images because we understood the pathology. And this is the 3D CT, you can see the thickening here in the ethmoid sinus and the ethmoid plate. This is the lamina paplicea being crushed upon, severe orbital fissure, and the bone destruction there. We always do the MRA and MRV to complete the images to see the pathology better. There was no abnormality in that. So what's the differential diagnosis of this lesion? Although, as I said, the images are pathognomonic. This is an aneurysmal bone cyst, multicystic lesion, filled of blood, etc. But what is the differential diagnosis? So wide. Malignant tumor, sinonasal squamous carcinoma. By the way, this is the commonest malignant tumor of the sinonasal group. Adenocystic, adenocarcinoma, undifferentiated carcinoma, owing sarcoma, the nasopharyngeal carcinoma. They look like our lesion, but they are in the same location, but they are different pathologies. Rhabdomyosarcoma, osteoma. Whenever you see arrows, these are not my cases. This is from Osborne Book of Radiology, but the others are my cases. Osteosarcoma, osteoblastoma, giant cell tumor, Clivus chordoma, one of my cases, chondrosarcoma, metastasis, lymphoma, esthesioneuroblastoma, ossifying fibroma, inverted papilloma, which is the commonest benign tumor of the sinonasal area, sinonasal fibroma, again one of my cases, and angiofibroma, neurofibroma, histiocytosis, etc. Intraosseous meningioma, sphenoorbital meningioma, hemangiopericystoma, epidermoid, fibrous dysplasia. The pathology is very, very wide. So to understand what you are going to do, you have to make a proper diagnosis. Mucocele, one of the commonest cases that come to the ENT clinic, giant cell granuloma, fungal infection. This was a Libyan chap with this major fungal infection. Allergic rhinitis, echinococcus, hydatid disease affecting the orbit, and the inflammatory pseudo tumor. So these are grouped together as sinonasal lesions or tumors. Why they are called so? Sinuses and nasal. Nasal cavity and paranasal sinuses are involved. They are lumped up as one sinonasal tumor. They like to invade via the route of least resistance, so they go into the cavity, the paranasal sinuses, the nasopharynx, lamina paplicea, cribriform plate, and so on. They account for 3% of all head and neck tumors. 3%. As we said, the commonest tumor is squamous. The commonest benign is inverted papilloma. So we did a few consultations for this boy. Ibrahim, you are here. See you coming, please.
Good morning. I had the pleasure to evaluate this lovely kid, and when I say lovely, he's a really lovely kid. And the situation is sad. He's lovely, and he has this disfiguring and bad tumor, and he was not born like this. It happened just months ago or something like that, a few weeks ago. So we as ophthalmologists, Dr. Ayman knows, Dr. Sura knows, we don't like to deal with kids, especially when they have this neuro logical problems because we have a lot of complex tests to do. So we refer them to pediatric ophthalmologist. So unfortunately, I'm a pediatric ophthalmologist as well. So I referred him to myself, and I continued his examination. When I saw him for the first time, his vision was counting fingers in the right eye. He was unable to do more than this. His left eye was perfect. Color vision is important. He was 0 out of 17 in the right eye. Left eye was 16/17. Visual fields were full in both eyes. I could not do automated visual field at that time, but I managed to do this by finger confrontation, and he was full to counting finger. And with fundoscopy, there was no papilledema or optic atrophy. In the optical coherence tomography, there was no thinning of the nerve fiber layer in both eyes with minimal changes in the ganglion cell layer. And this is the OCT. We evaluate many areas in the retina. This is the macula, the ganglion cell complex. And there's an automatic software that will tell us whether there are significant changes or not. So this is the right eye. There is no significant change compared to the change in the color vision and visual acuity. This is the left eye. Yes. Minimal changes as well. And we expect to have some structural changes with that decreased visual function, counting fingers, visual acuity, and 0 color vision. We expect to have some. So we don't have much of a structural change in the optic disc. This is the optic disc analysis. The machine counts the nerve fiber layer around the optic disc, and it is good. So this is an indication for us that if we intervene, usually I don't write impression because sometimes most of the time the cases are straightforward. We want just to document, but sometimes I write my impression. And this is my impression. There's a right optic neuropathy and proptosis that seems recent because the structure of the optic disc looks normal while the function is subnormal. This indicates that surgical intervention should be carried out soon in order to improve vision. If we don't hear this message, the patient will go blind in a few days to a few weeks. So if you listen carefully, you might hear the voice of the optic disc. Please, Dr. Speh, help me and intervene in 1, 2, 3 days, something like that. Thank you.
So Raymond, do you want to comment on this?
I think what Dr. Rahim said is covered the whole subject. Just when we are assessing, as you said, we assess the mobility. Mobility was good, and this is strained. While there's a tumor pushing from the nasal side. As I said, there's dystopia. You put a ruler horizontal line. You will see that, and it's always good to measure how
much is the proptosis in millimeters?
It is mentioned actually.
Yes.
There was some sort of limitation, and there was some dystopia as you.
I just to stress what Dr. Rahim said.
Yes.
This was said beautifully by Dr. Rahim. Is that
Ibrahim me, you mean?
Rahim. I love you both. So the optic nerve. There's an optic nerve fiber swelling, but they are not dead yet.
Yes.
It was left, they will be dead. Thank you for him. You've done a great job.
So, Sarah, you want to comment? No. Thank you. Any new ophthalmologist? Okay. We consulted our pediatrician at that time. It was Edward Sakha because, as you said, creatinine is 4.7, and for him, this may indicate renal failure. So it's minor thing, but it's important for kids to remember creatinine is high for the patient age. So he said, we'll repeat this because this is high for his age and weight. And we repeated it was open time, so I said it's okay. We asked Dr. Auni al-Madani, I don't know whether he's here, Dr. Auni? No, we asked him to come because we did a cardiology consultation because of the sinus arrhythmia, and he considered this to be okay. It is not really pathological, and we can proceed with the surgery. So, pediatric cardiologist, Dr. Ayman Auni al-Madani. Anesthesia, patient was announced fit for general anesthesia, American Society of Anesthesia Grade 2. Dr. Aisha, you are here?
Yes.
What does it mean, American Society of Anesthesia Grade 2? Dr. Aisha is the anesthetist in this house.
صباح الخير جميعا. طبعا the ASA classification has been developed by the American Society of Anesthesiology. It's a simple and actually a quite reproducible method for assessing the risk of surgery for patients presenting for us for surgery. He's been classified as ASA2 because ASA1, these are patients who are completely fit and healthy. They have no chronic medical illnesses. As for grade 2, which means they have medical illness, as in this guy, in this boy, so he has a tumor, so we classify him as grade 2, which means his health is controlled and the condition he has no effect on his physical status. As in grade 3, as opposed to grade 3, these patients have some limitations in their physical activity. As in grade 4, they have a constant threat to life. Meanwhile, grade 5, they have constant threat to life, whether they have surgery or they're in prison for surgery. And the American Society of Anesthesiology added the letter E in case the patients actually present for emergency surgery. Thank you.
Your seat has been taken, so you can sit there. So what is the difficulty in treating surgically aneurysmal bone cyst? What are the difficulties there? Usually it affects young group of patients. And young group patients are growing patients, so you want to take care of their sinuses, their bones. Blood loss is very high. Accessibility is difficult. You are talking about skull base. So these are the difficulties, which we will see in the video coming. So sinonasal tumors in general are almost always treated by surgery. What kind of surgery? Either craniofacial approach like you will see in our case, or by endoscopy. Exceptions, lymphomas, multiple carcinomas, they are treated by chemo and by radiation. So surgery is the upfront treatment of these cases. It is microscopic surgery. It is not done by the naked eye. Neurosurgery is microscopic surgery. If you see a neurosurgeon operating with his naked eye, he is living in the Middle Ages. And the aim is total resection whenever, and it is applicable. So you don't just go for radiological triumphs. Just remove the tumor, regardless of what happens to the patient. So you want to do total resection with respect of the health of the patient. Some anatomy of the area we are going to, we are going here. In this area, this is the orbit made of 7 bones, 7 arteries, 7 veins. This is the greater wing of the sphenoid. This is the process of the maxilla, process of the frontal bone, nasal bone, maxilla itself, severe orbital fissure, inferior orbital fissure. The lacrimal sac is here. So anatomy that you should remember. A magnified view, greater wing of the sphenoid making the lateral wall of the orbit, the severe orbital fissure, up to the optic canal is there, and here is the lacrimal sac. This is the maxilla. So this is the nasal septum. This is the medial wall of the nasal septum, right or left, and the lateral wall is actually the medial wall of the maxilla. You have to remember this anatomy, and then put this soft tissue on top. You have to remember what is the medial canthus ligament, because it's important. If you cut the medial canthus ligament, you can remove or move the whole of the globe and go to the medial wall. And one thing to remember is the lacrimal sac and nasolacrimal duct. You have the superior inferior canaliculus going to the sac. So you can mobilize the whole thing this way so that you will go this way. So here we've cut the medial canthus ligament, and this is the sac and the sac and the duct. And once you do that with the retractor, you can move the whole thing, come to the medial wall of the orbit, which is the lamina popliteal of the ethmoid bone, and you will face the anterior ethmoidal artery and more posteriorly the posterior ethmoidal arteries. Both are branches of the ophthalmic artery. You have to know the anatomy of the sphenoid bone, made of body, greater wing, lesser wing. Lesser wing contains the optic canal. Between lesser wing and greater wing is the superior orbital fissure. The body of the sphenoid contains the sphenoid sinus. It has two legs, the medial and lateral pterygoid blades, and they are articulating with the hard palate, with the palatine bone. All this anatomy should be in the back of your mind. If you go more, this is the orbit, this is the maxillary sinus, this is the intraorbital nerve going in the roof of the maxillary sinus. So the medial wall of the maxillary sinus is the lateral wall of the nasal cavity, and it contains the turbinates, inferior turbinate, middle turbinate, and superior turbinate. The nasolacrimal duct opens here. The duct or the range of the maxillary sinus goes here in the middle turbinate. Again, the septum, inferior turbinate, middle turbinate, the maxillary sinus. We are going back to the posterior wall of the maxillary sinus. And if you remove that, you will come to the pterygopalatine fossa. You can see pterygoid muscles, you can see the pterygoid ganglion. Again, here you start to see the eustachian tubes. If you go further down, you'll come to the infratemporal fossa, and you'll see the maxillary artery and all the nerves there. Should one know this anatomy, if one goes into this region, it is a must. You don't leave it to the ENT colleague or the facial maxillary. As a neurosurgeon, you should master this anatomy. Again, the relationship of the maxilla that articulates with the palatine bone, that articulates with the pterygoid plates, is very important. Here is the nasal septum, maxillary sinus on the left, maxillary sinus on the right. So the medial wall of the maxillary sinus, which is this, is the lateral wall of the nasal cavity. Septum, medial wall of the maxillary sinus, infraorbital nerve. Why I'm mentioning this? Because you're going to see this in the video. So medial wall of the maxillary sinus with the turbinate. And if you remove that, you will come here to the nasal septum and into the sphenoid ostium and sinus. We will go there, you will see this, you will see all this anatomy that we mentioned. Constant form should be detailed, and we have to describe what exactly we are going to do. Myself and Dr. Sartawi are doing the surgery, what is the patient complaining of, and the most important, that the aim of surgery is to remove the tumor completely, but this is impossible from a practical point of view. You cannot remove every simple piece of tumor in the skull base. The aim of surgery is to excise as much as possible, and this is all depends on what we find during surgery. This is very important for the patient family to know. And you mentioned the complications. Complications are really high, 30%. CSF leak, infection, bleeding, brain catastrophes, even death. So this is the anesthesia. It's a nasal intubation. This is myself, Sartawi, and the patient being carried by his father. And Dr. Abaisha, again, why nasal intubation? Why not usual?
Good morning again. بصراحة موضوع النازل intubation has been a topic of debate for the longest time. I think in this case, maybe the anesthesiologist has decided to choose it because in pediatric patients is much more well tolerated post-operatively. And on awakening the patient, they are much more tolerating the tube while awake. With all honesty, I wouldn't dare going for nasal intubation in this case. As Dr. Ibrahim Sbeh mentioned, the tumor was in close proximity to the nasal cavity, especially the ethmoidal sinus and the maxillary sinus. It's a very highly vascularized area, and the complications of nasal intubation is tremendous, especially torrential hemorrhage. And in pediatric age group, the adenoids are large, and you don't want to compromise the other nasal cavity, especially that the right nasal cavity is involved with the tumor. It has its proponents and opponents, especially going with the complications. The major indication for nasal intubation is to go with the dental surgery, and if the patient has severe trismus, and in case of difficult intubation, using a weak fiber optic intubation. I was not involved in the management of this patient, so I wouldn't comment on what my colleague has done. But if it was up to me, I wouldn't go for nasal intubation.
Okay, so this is the pre-surgical set. Dr. Sartawi, who's a facial maxillary surgeon, will do this modified Wilber-Ferguson incision. Wilber-Ferguson goes up till here. Modified is this addition. So this is the opening of the skin subcutaneous tissue, and then he will come to the maxilla and he will make 3 cuts, this way, and this way. And then that piece of the maxilla will be removed. And this will open to be the road. So facial maxillary surgeon put me on the tumor directly. This is the incision on the Wilber-Ferguson, and this is where the piece of the maxilla has been removed. What you are seeing here is the lacrimal sac and nasolacrimal duct. So you can work on top and you can work below. And here is the infraorbital nerve going this way. You have to keep that because it's important for many things, including kissing. So after Sartawi, I started using the microscope. We're using navigation. Navigation companies here, isn't it? Nasib, yes. So we're using the navigation. Why? Because we are in a critical situation and we need to know where exactly we are. So in each step of the surgery, I make the arrangement to see where I am. So I know here that I am in the posterior ethmoid going into the sphenoid. So here you see it in 3 dimensions. You know exactly where you are. Here we are at the anterior clinoid, laser wing of sphenoid. So it's important adjuvant to your anatomical knowledge. I always say, and the navigation people knows this about me, I say you are the navigator, your brain is the navigator, you as a neurosurgeon is the navigator. But to find somebody to say, yes, you are right, is assuring. If you count completely on the navigation, you are a failure. But if this confirms what you know, that's a good success. So let's see the surgery.
Would ultrasound be helpful if we don't have any navigation?
I've tried it. It's not as good as the navigation.
Obvious.
Okay. So the orbit and the globe is here, and the nasolacrimal duct is here. I'm working on top of it. So the maxillary sinus has been cleared of the tumor by Sartawi. Now this is the rim of the orbit, frontal bone. I want to trim it so that I will have better access, better vision. And you can see the tumor is very, very vascular. Here is the nasal septum here. It's completely destroyed with the tumor. You will find a little bit of cartilage here that is seen, but it's totally destroyed. Here we are in the nasal cavity. Here we are in the roof of the orbit, roof of the ethmoid bone. Very vascular, multicystic. Look at this. And actually, this film shows the tumor to be vascular, but in reality, this is the nasolacrimal duct and sac. You can see now the amount of bleeding which is there. So I'm not surprised that the patient developed only the proptosis 3 weeks before admission, because any sudden hemorrhage in this cyst will cause the proptosis.
Right? You say that the septum is destroyed?
Part of the septum is destroyed, yes. Not all of it.
If destroyed, you will see the tube, the other side.
Yes. On the other side, yes, but the microscope is not directed towards the tube. We will see it now. You will see the sphenoid sinus. Here's the dura. The white stuff is the dura. The dura, which is in the floor of the anterior cranial fossa. In fact, there is some CSF leak there. And as I said, they are stuck to the dura, but they don't penetrate it. So it's a tedious process. Dura again. Piece by piece. Here's one of the cysts filled with blood. I just want to show how the amount of bleeding for our neurosurgical residents to see what kind of lesion they are going to face if they face such a case in the future. The white is dura in the roof of the ethmoid, dura in the floor of the anterior cranial fossa. We are cutting it with scissors here. And now you will see bleeding. No, this is the sphenoid sinus. So this is the tumor within the sphenoid sinus. Remember, the eye globe is here. This is the nasolacrimal duct. I'm working on top of it. That's why you will not see the tube, because the tube is down below. Sphenoid sinus. That's the sphenoid sinus. Here I'm using the probe to see exactly where I am. I know I am in the sphenoid sinus. I know where I am. I do the navigation. Yes, you are in the right place. If I find that the navigation is giving me information other than what I know, I ignore the navigation. Here is the bleeding that will happen now from the ethmoidal artery, posterior ethmoidal artery, which is a branch of the ophthalmic artery. Both are branches of the ophthalmic artery. Again, you have to know this anatomy, otherwise you will not know what's happening. Heavy bleeding from the ethmoidal artery, ethmoidal artery, which in this case is magnified, is big, because it is hypertrophic, because the tumor needs blood. So you have to control yourself before you control the bleeding. So we control ourselves, control the bleeding, and this is the artery that's going to be death-arised.
Excuse me, Dr. Sabea, you need to share the screen. We're not seeing the screen.
And then you continue with the resection of the rest of the tumor. I'll just jump.
We're not seeing anything.
Again, the dura is seen here, the white stuff.
No, I'm just seeing a slide that says surgery 27th of September. It's not changing at all.
Perivascular tissue of the tumor.
Yeah.
This is where the anterior clinoid process is. This is the remnant of the bone. This is washing of the cavity, big cavity that is left. You make sure there's no blood there. This is the dura of the anterior cranial fossa coming down. And once we control the bleeding completely, we put this gel foam to prevent bleeding and to stop any CSF leak. And then we put this so-called dural sealant fluid that tends to be tough jelly to prevent any CSF leak. Okay. What's up? What's it moving? I finished my job, so Dr. Satawi waiting, sitting, sipping coffee and tea. Finished, he comes in, he put the piece back. This is the piece that he removed. And then he will fix it. You can see these grafts, absorbable platelets and screws, because this is a giant, is going to grow. You have to make accommodation for that. And this is the suture wound, as it seems, in the dressing. Histopathology, Dr. Parsa.
Aneurysmal bone cyst is common in children below 21 years of age, but not in the skull. In the skull, it's extremely rare. So this is the first time that I see aneurysmal bone cyst in the skull, although we have seen this in the bone in good frequency in children less than 20 years of age. This was sent for frozen section by Dr. Sartawi, the first specimen, but Dr. Ibrahim actually told me he suspected this aneurysmal bone cyst. As a pathologist, when I diagnose something, I listen to my clinician, but I don't make a diagnosis according to his wish first. I always have to have all my criteria to call it. So this is the first frozen section piece that they sent it to me. You can see this is fibroblast intersecting with each other, and this is not aneurysmal bone cyst component. And I told them this is a benign fibroissus lesion that I have, because we as a pathologist, we only can diagnose what we can see in the microscope. This is an osseous lesion, and this is fibroblast, and this is, I call it benign fibroosseous lesion. Again, you can see the ossification and the fibroblast. So this was the first part of the specimen that was sent for frozen. I called it benign fibroosseous lesion. I did not see aneurysmal bone cyst. But then they send another specimen, and you can see here is different from the previous one. Here's the nasal mucosa, and here's a component of the aneurysmal bone cyst. You can see so many giant cells. This is at low power, and this is a vascular space lined by spindle cells. We'll show you higher power, but this is the component that actually we call it aneurysmal bone cyst. And this was the component that was sent originally in the first frozen section. You can see again the nasal area, see how the tumor is reaching the nasal area. And this is the vascular spaces that are filled with the blood with the fluid level. And typically aneurysmal bone cyst, you see many giant cells, osteoclast type giant cells, and fibroblast, benign looking. Mitosis usually is rare in these cases, although we allow some mitosis. And again, you can see the nasal mucosa, see how tumor is reaching up to the nasal mucosa, and you can see the vascular spaces here. So this was, to me, the second frozen, typical of aneurysmal bone cyst. You can see the vascular dilated spaces that lined by spindle cell fibroblast, and this is the giant cells component with the spindle cells lining, and this is the one that was received, the component that was received in the first frozen section. So, and again, you can see more of the vascular spaces typically lined by spindle cells, and these are the giant cells around the vascular spaces. The giant cell, all these are reactive actually, not neoplastic. And this is again a lot of blood, and this is the giant cells. And you can see this is the vascular spaces that are lined. These are very thin vascular spaces and easily can be disrupted and bleed. And these all the multinucleated giant cells, osteoclast type. It's very important to be osteoclast type giant cells. And you can see some lymphocytes in between, but there's a lot of spindle cells. You can see more of the vascular spaces, some of them hemosiderin laden. And this is see how thin is the vascular space, very fragile. That's why they can bleed easily. And the surgeon should should know the pathology of the aneurysmal bone cyst, so he can be prepared for the bleeding. Again, you can see here, this is the fiber and vascular spaces, histocytes in the middle, and this many multinucleated osteoclast type giant cells with fibroblasts. The tibia is minimal. Again, this is the mucosa of the sinuses, or the nasal mucosa, and this is the tumor. And again, here is the same thing. We took so many pictures in this case because it's really a rare case. In rare cases, I usually like to take so many pictures because you don't know probably someday somebody will report it. And these are the multinucleated giant cells and vascular spaces filled with blood. Again, multinucleated giant cells, no mitosis, and see the vascular spaces, they are not lined by normal endothelial cells. These are fibrous cells, and that's why they are very easily to bleed. Again, you can see many multinucleated giant cells, dilated vascular spaces. Higher power, you see the multinucleated osteoclast type giant cells and many blood vessels. Some of them, the larger ones, are aligned, and then in between the tumor cells also there's so many vascular spaces. That's why it's so much prone to diagnosis. So this is typical histology of benign aneurysmal bone cyst.
Two things I want to mention. Thank you, Dr. Farshad, because he kindly came this morning, although he has a paper to present down in a major international pathology meeting that I did see. So thank you for coming. The other thing that I won a bet. I had a bet with Dr. Sartawi. I said, this is aneurysmal bone cyst. He contradicted me. And they said, the loser will take the staff of the theater, nurses, everybody, residents for lunch. So Sartawi took he paid lots of money.
Happily.
Karshatu Kawar. Post-operative course.
Dr. Ibrahim, for you,
Sure.
this is a feedback good from the authorities. The
Yes.
surgeon should take so many sites samples rather than
Absolutely.
rely on
Not
one
just a little bit thing.
a little bit and that's it.
Worse than this, some people would just take one specimen from one corner and they leave the theater and they close. And then the pathologist said, I don't have enough tissues. So patient woke up 15/15 on table, which is our habit. Nobody leaves on a ventilator. And this is him. This is his mouth and lips. This is his eye. And immediately the very following day, we did brain orbital CT scan just to show the air bubbles that we were there. We were here. Again, maxilla, ethmoid. So, done a good job. Okay, his course was uneventful. He was discharged on the 4th postoperative day. And this is him the day he left hospital. Eye movements are okay. Eye starting to come back to position. Still there is proptosis, but we are still very early. And this is the discharge summary. Again, our residents knows this, that we demand such a discharge summary, not the single piece of paper saying this was admitted and so, discharge and so and so. MRI was done, that's it. It's not enough. It has to be detailed like this, because this is only the right of the patient to have. Everything is done in figures and in numbers, the incision, the pre-op, the post-op, and the recommendations. Again, the recommendation should be clear, the medication should be clear, etc., etc. This is when he came back to my clinic 1 month later. Once started to heal, no proptosis or minimal. And this is the follow-up ophthalmology Dr. Ibrahim did for him, and he concluded that there is improved visual acuity, color vision, and appearance. And this is the follow-up 1 year later. You can see very good job. We gave no radiation, we waited, because this is a self-limiting disease. If you remove much of it, most of the time what is left will regress. This is with contrast. So this is extremely, extremely good result. And this is the boy 1 year later. And this is his wound have healed very nicely. You're barely able to see that. In 2 years' time, it will vanish completely. And no proptosis whatsoever. So just a quick information about the ABC aneurysmal bone cyst. the WHO definition, this is a benign cystic lesion of bone composed, as we have seen, of blood-filled spaces separated by septae. Septae are made of fibroblast, osteoclastic giant cells, and reactive moving bone, and they rapidly enlarge and cause bone destruction. It is 1% of all primary bone tumors, young age, females more than males. It can affect any bone. There's no bone which is immune from the ABC. And if you look here, 21%, 13%, they are long bones. Long bones are the commonest: humerus, femur, tibia, pelvis, and then comes the spine, and then comes the head. So this is humerus involved, clavicle involved. This is lumbar spine involved, classical. This is the thoracic spine involved, one of my cases. And this is another case of mine. And you can see this is from Yemen. This is cervical. And as I said, they can affect the skull. They love the skull base. And they love the mandible for no reason. You can see this. The treatment, as I said, surgery is the first line. In block resection, curettage, bone grafting, but don't do biopsy because it's very vascular. You can embolize if you like before surgery or as a palliative treatment. I've never needed to embolize the aneurysmal bone cysts, and this is a case of embolization of this aneurysmal bone cyst. Dr. Sazi, if you are here, do you do these cases of spine embolization?
Some of these cases.
Dr. Sazi Haddad is interventional radiologist.
We started doing some of these cases being referred more and more. There is a cumulative literature, maybe you can do angiogram to start with.
To see the feeder vessels, and in some cases you can do embolization actually. Now the results are really acceptable. You can have healing in about 30% complete cure, and the majority you have to probably do surgery after that or repeat the multiple sessions to cure the lesions. I don't have much experience in the skull-based ABCs, but I've done cases in the pelvis, in the long bones, and even the cervical spines. And usually when it's difficult to surgeons, that's when they are referred to us for embolization. Yes, embolization is an option, I believe, and it can be as a treatment or part of the treatment pre-operative.
Okay, Farid Al-Adham, what are you? Farid, can you comment on embolization?
I think it's exactly as you mentioned, it's a palliative mode. So if you don't have the expertise to resect the tumor, probably would be an option. Skull base would be a place where you should be very hesitant before you do it, because probably have more risk than benefit there from embolization. So in the periphery there is an established role, but as I said, it's mostly palliative.
And here you embolize the intercostal arteries, yes?
Yeah, that's the role, but you have to know exactly where you are. A lot of the times the intercostal has some radiculomedullary branches, so you want to make sure you don't paralyze the patients.
Okay. Anybody?
I just wanted to comment on this.
Dr. Ala Raqat, neurosurgeon.
Yeah, well, I believe embolization for the spine cases really helps in decreasing the main morbidity, which is bleeding. The cases I did, I usually try to embolize before.
Dr. Ala trained in France and Lille, and they are doing a lot of spine cases. Anybody? Please.
I agree with Dr. Al-Khat, because
more and more people are getting more courageous with doing embolization because of the newer embolic material that we have. When you do onyx or squid, you're probably very safe. You know your vessels, as Farid said, and then you can embolize the part that you want and spare the part that you don't want. So yes, I think it's getting more popular now.
Thank you very much. So some people give radiotherapy, but for me, radiotherapy is a palliative treatment. It is not an upfront treatment. New lines of treatment is intraregional injection. Intraregional injection of alcohol, calcitonin, methylprednisolone. Sometimes they combine calcitonin and prednisolone. This is a new trend in treatment of these cases. Anybody want to comment on this? Please.
I think this is actually getting. This is actually a very important part of the treatment plan for these lesions that should be considered in the appropriate clinical setting where you don't have an acute situation, because there is now well-established good outcomes, and not necessarily with, there are difference. In addition to this, we'll add doxycycline, actually a good sclerosing agents in these lesions, and we've seen multiple patients we've treated personally that will completely fill that cyst. And I'm talking about peripheral lesions. We're not talking about skull-based lesions. So it definitely has a big role.
Thank you. Any comment? Anybody wants to comment? Okay. So this is a paper, the first paper that was published, one of the major papers, 2008, about this percutaneous intralesional injection of calcitonin from Japan. And you can see the region, and this is the intralesional injection of calcitonin and prednisolone. Could they regress? Could you leave them to regress? Some people say they are spontaneous regression. Absolutely not. Very, very rare cases, a few cases, maybe 4 or 5 in literature about spontaneous regression, and they are in all patients. So you have to have active treatment for these cases. With this, I finish, and the floor is open for discussion. Any question, please?
Actually, if we can go to one of his images,
Sure.
showing the surgical incision. Actually, the improvement was dramatic in this case from visual acuity of counting fingers. Last follow-up was 0.9. So he managed to go from almost 5% to 90%. Color vision improved, his visual field improved, but always there's, can we go to that incision photos of the same patient? Sure. I want to show them something. So the improvement is dramatic. One point is, how do we hide that? Yes. Okay, we can. How do we hide this incision post-op? So Dr. Sartan and Dr. Speh did a very good job, but sometimes we do something for this at least. We always put glasses with thick frames on the patient eyes so that they can hide this part and this part. And this is a male after the age of 15 or 20, he will have a mustache. This part will be hidden also. So we are left only with this 2 or 3 centimeters that will be apparent for people. So all this incision, 10 to 12 centimeter incision, will be only 2 centimeter incision.
Morning. So not only there's nothing benign about a benign brain lesion, there's nothing benign when it comes to the brain about a non-neoplastic brain lesion as a bone cyst. Few things about the potential management of those after proper surgical tackling of them is that you may follow this with radiotherapy if you're concerned about what you've done after surgery. That is, if you want to complete that, that can increase the progression-free survival or relapse-free survival. Other agents that we use in other contexts, anti-resorptive agents like IV bisphosphonate and the risodronate and the like, can be used in the setting, and there is increasing data about their use in bone cysts. But more importantly, before that, a priori, what could this have been? Because there are a lot of things that could have masqueraded as a non-neoplastic brain lesion. And a good example of this is osteomas and osteosarcomas. And this is and this is actually quite important because they can actually look exactly like that, and the treatment is radically different. Giant cell tumors where the use of IV bisphosphonates and denosumab and the like actually has a real role in the measurement post-operatively. Rhabdomyosarcoma, where it really can look like this lesion, and the
treatment is radically different, and it's mainly based on chemotherapy. Other things that I want to highlight is the possibility of this having been Ewing sarcoma. Is this having been Ewing sarcoma, where I can move it. Where the treatment would have been multi-agent, high-intensity, alternating chemotherapy with curative intent. Other things that could have been really treated dramatically differently had this been histiocytosis, which really could have looked exactly this way. And I'm going to leave this to the last. Osteosarcoma, the chemotherapy part is really integral. The surgical part is integral, and the radiotherapy part is integral. And it's a multi-modality approach. Now, nasopharyngeal carcinoma can cause something like this. Some chondrosarcomas can cause something like this. And even lymphomas can present in a manner that is very similar to this. Lymphomas in this region would not qualify as primary CNS lymphomas. These would be extranodal bone lymphomas, where they won't even need high-dose methotrexate in their treatment, and what they will need is cyclical multi-agent chemotherapy, again with curative intent. These are actual cases. This is not hypothetical mental exercise. These are actual cases that could have masqueraded as that. And the danger is having dismissed them as potential bone cysts or benign lesions, and with disastrous consequences. Now, this non-neoplastic, it's not even benign, it's non-neoplastic mechanism left alone. It has severe morbidity and mortality. And all of these that could have masqueraded as left alone would have caused the death to the patient.
Okay. Any questions, any comments? Please.
بيأثر على الثيرميك evaluation لما حكينا انه الفانكشن اوف ذا اوبتيك ديسك كان deteriorated، بس الاوبتيك ديسك نفسه ما في يقلل او في شيء. سؤالي لاي درجه نقدر نعتمد على الفانكشن تشخيص السودو تيومر سيربراي او في الهايدروكيفالس ونشيت التريتمنت بس اذا كان الفانكشن اوف ذا اوبتيك ديسك.
Brian, you want to point?
So we have always this mismatch between function and structure.
We have always this mismatch between function and structure. Sometimes the structure tells us about the function, sometimes it is not. So I can show you a frank florid papilledema with good visual function or good visual acuity, accepted visual acuity. So basically what is important is the function, and the function probably goes first, then the structure in some cases, and vice versa in other cases. Actually, was your question about ICP, increase ICP?
السؤال مرة ثانية. function كيف اتاكد انه هاي الفانكشن كانت من الاوبتيك ديسك؟ واذا تاكدت خلاص يعني I can start treatment. انا ما في عندي تيومر في الديسك، في عندي هيدروكيف شاكك انه هذا is it active هيدروكيف ولا arrested هيدروكيف، ولقيت الفانكشن انه deteriorate.
So basically what you do is you follow up the patient. If the function is deteriorating, that's an active disease. Sometimes you find visual dysfunction and you follow it. It is there for a long time. It is not progressing, and that's why we do follow up.
Yes, Maurice, to answer this question too.
Yeah. One thing that you can get the help of is doing visual evoked responses. Now, if you do a visual evoked response, you can get an idea whether the damage is axonal or demyelinating. Now, I don't know whether any of you have seen a visual evoked response. Basically, you put a patient in front of a screen, and then you measure the time it takes for the image to get to the occipital cortex. You can actually look at the function of the optic nerve, optic tract, all the way back to the occipital cortex, where it is stored. Now, what you will get, you'll get a nice
response. Now, if the response is large and delayed, that usually tells you it's a demyelinating. If you get it very small and delayed, that's axonal. And if it is really axonal, then the prognosis is bad, because that means there is damage to the axons. So that might help you in differentiating between the two. I mean, if you have a case like this, it would have been quite useful to do a visual evoked response. And if you find that it is really the actual response is quite big, but it will be, as I expect, delayed and not really much affected by as far as how big it is, then that would tell you the prognosis is probably better. Now, if you find somebody who's really lost the signal, or it's really very small, that will tell you it is axonal, and maybe the response will not be as good.
I want to ask Ammar and Baideen about this. Papilledema and pseudo-papilledema. How can we differentiate, especially for young people?
Simply, both they have normal visual function, and visual field can differentiate, and fluorescein angiography can differentiate. But just one comment regarding the patient. The patient has optic neuropathy in the sense that he has impaired color vision. He was counting finger, so the lesion is proximal to the lamina crepiosa. That is to say, the posterior part of the optic nerve. As Maurice said, you can do visual evoked potential to just confirm the presence of the optic neuropathy further, but simply you can do a simple clinical bedside test, just doing looking for markers, gun pupil or relative afferent pupillary defect. So I think clinically we can tell easier than before going into visual evoked potential.
And sometimes because of the adhesions of the arachnoid around the optic nerve, sometimes the intracranial pressure is not transmitted to the optic nerve to see it by fundoscopy. Isn't that correct?
Yeah.
دكتورة سنة.
طبعا أشكر عمل الفريق بينكما، طبيب العين الحاذق وجراح الأعصاب الرافع. هذا جيد، ونفتقر كثيرا أحيانا في بعض الأحيان في الأردن لعمل الفريق. تعليقي، رأيت في الورقة ذات الموافقة كلمة فوبيا. كطبيب تعرف أنها فوبيا، ولكن هل المريض يفهم ما معنى الفوبيا؟ لماذا لا تعطى كلمتها الصحيح باللغة العربية؟ إنها رهاب الضوء. عندما تقول رهاب الضوء يفهم المريض عندما نوقع على ذلك ما معنى الفوبيا. شكرا.
دكتور عتامني، راديولوجيست. دكتور
كومنت صغيره، يعني احنا لما ندخل اناليزمال بونسيست على طول بيخطر على بالنا الجاينت سيل تيومر. الفرق بين الاثنين تقريبا، يعني مش دائما، انه الاناليزمال بونسيست يحترم البوردرز والجاينت سيل لا يحترم. سؤالين صغار دكتور ابراهيم. اولا التيومر او الاناليزمال بونسيست هل له وول او ما له وول؟ وقديش نسبة الانسيدنس اوف ريكارنس في الاناليزمال بونسيست؟
The last question first. The incidence of recurrence of aneurysmal bone cyst is 20 to 40%, and there is no border that you can see. It is made of many septations, many compartments, so there's no border that you say I have completely removed it. Especially that it goes to the bone, especially if the bone is discolored.
Thank you very much for a very nice lecture. My question, you said that the MRI findings, especially fluid level, is pathognomonic. But I think it's not pathognomonic because there are different lesion can give fluid level as giant cell tumor, chondroblastoma, and osteosarcoma. So I think it's not pathognomonic, but if you find multiple fluid level with sclerotic or hypodense lesion into one weighted, with multiple citation enhancing and the fibrinotic band enhancing is in favor of aneurysmal process.
If you see bone level, fluid level in a bony lesion, the first differential diagnosis is aneurysmal.
Yes, one of the differentials. Thank you.
Hence, Dr. Atami, what we discussed is that the possibility of this having the giant cell tumor or chondrosarcoma or osteosarcoma, these are actual real parts of the differential. These were actual cases. It's not hypothetical. What else could this have been? And the importance of the surgical approach in all of those cannot be overemphasized. I can't agree with you more.
Dr. Mohammed Al-Asad, ENT.
شكرا. The first slide, you said about the way of management. You said the external approach and then endoscopic approach.
Sure.
Just to mention that these things, it could be, in each case we have to evaluate, but it could be done endoscopic without any external approach. Most of the maxillofacial, they like external. But most of the ENT, they would prefer endoscopic. Now endoscopic has become a very, very wide approach, and we can reach to the skull. The main things for the patient was the eye. And this can be easy when we open the anterior mold, the lamina papalucia will be pushed and then the eye will come. And we have seen, I had many cases, on the spot, on the table, the eye comes back. And with the ophthalmologist with me, once we remove the tension about the lamina, the eye comes ptosis or deviated or double vision or something like that. This is just to mention, and it is up to the surgeon and the approaches. Thank you.
So the message from Dr. Mohammed said that there is an endoscopy approach for this, which I agree to. My question is, can endoscopy remove such a giant tumor? I say no.
My question is about, was there any lacrimal syringing done pre or post-operative?
I can't honestly remember whether this was done or not. Most likely,
symptomatic, no symptoms.
yeah, no symptoms. Yeah, exactly. But I can't really, with honesty, say yes or no.
Question: if this occurs, you go back and do another surgery?
Yes.
You do an angiogram, injection.
I would go for surgery. And if there is remnant, I would think of other options. Surgery is the key for this. Dr. Sazif Haddad, interventional radiologist. Any questions? Okay, with this we finish. I thank you all. And we will meet next week at the same time with a very, very interesting case. It is toxoplasmosis in the spinal cord presenting as a spinal tumor in HIV positive patients. So we will raise the question of HIV, etc. So thank you very much.
ابراهيم الدهني زي دم very nice, very special. ده يدرس على الأطفال.
طبعا.
Very interesting.